Dear students, we will discuss about image, very common image as such as far as abdomen is considered. Just see what this image shows. See that diaphragm is seen here. It's a plain extra abdomen, of course, lower chest should be covered. Pelvis is covered. And you can see the dilated bowel. You can see the valvulae conventis, that's jejunum. You can see the multiple air fluid levels. Another X-rays, different patient, of course, dilated bowel again, multiple air fluid levels. Diaphragm is seen here. So multiple air fluid levels, you can see that. So this is plain X-ray abdomen with the lower chest. Now there is a difference between the KUB X-ray and abdomen, plain X-ray abdomen and chest. In plain X-ray abdomen, diaphragm should be covered and proximal pelvis. And it is a low penetration X-ray. Technically, if you write like that, they understand technician. It is a low penetration. Whereas in KUB, kidney, ureter, bladder, urethra has to be covered. Diaphragm need not be covered. It is a high penetration X-ray. So you have to, it is mainly focused on the retroperitoneum. Kidney, ureter, all these things are retroperitoneum. Kidney, ureter and bladder, urethra. So it is high penetration X-ray. That's the technical difference. Diaphragm will not be seen visually in KUB, whereas entire pelvis is commonly seen. So you should know how to differentiate between the plain X-ray abdomen and KUB X-ray. So by looking at the X-ray as such, these are the features. So findings: multiple air fluid levels. Remember, more than 3 suggests intestinal obstruction. Normally fundus shadow 1, duodenal 2, and third maybe there in the cecum. 3, anything more than 3 suggests dynamic intestinal obstruction. So more the air fluid levels, distal the obstruction. Jejunum, how it looks like dilated bowel, valvulae conventis. Typical it is. If you look few X-rays, you will understand that. And whereas ileum is characterless, no smooth it is. Whereas colon has got haustrations like this. Haustrations. This is called haustrations. Colon has got haustrations. So this is how exactly we'll identify. Now once there is obstruction, proximal air, initially proximal bowel which get dilated and increases the peristalsis. So air is get pushed because of the pressure into the fluid distal to that, but proximal to the obstruction. So air gets churned into the fluid, air churning. So eventually, because of the fatigue, peristalsis seizures, bowel becomes non-peristaltic. So in that situation, each loop of the bowel contains air churned fluid. So air will be, when in erect posture, air comes to the top like a dome and fluid level will be there. So air fluid level, so number of more distal the obstruction, more air fluid level, more loops of bowel will be there. So more air fluid levels will be there. So air fluid level is significant because air gets churned into the fluid, collects in each loop. Once air is peristaltic, fluid will not or air will not move. That's the reason. So there is a typical air fluid level number, more the number distal the obstruction. Remember, observation, valvular contents and characterless features. So these are the causes. Remember, adhesion and hernia are most common causes. So always in such patient, examine groin for hernia. Previous history of surgery is very, very important. Congenital adhesions also equally can cause intestinal obstruction. All other things, growth in the colon, ileum and so on. Tuberculosis can cause stricture. Congenital, I already told, congenital stricture. Intussusception, telescoping of the one bowel to the adjacent bowel can cause, especially in children. Worm bolus, again common in children. So many other causes, remember. Very common acute abdomen condition, which you remember in most of the patients. CT is very ideal diagnostic investigation, especially plain CT. And surgery is the treatment in all dynamic intestinal obstruction. Remember, there is no conservative treatment. Initially, for resuscitation with the rice tube aspiration fluid to optimize the patient. Then surgery, you have to open and do laparotomy and do the needful as such. So go through my clinical methods, how to examine acute abdomen and other things with the video, and manual for detail about intestinal obstruction, and surgical procedure, resection, anastomosis, adhesion, laparoscopy, all those things, and tissue approximation for suturing, and my digital video lectures, entire thing cover for UG and basic for PGs. So students, I hope you understood this X-ray very clearly. Thank you very much.